Are you ready, Ravi Kiran?
Yes, sir.
Yeah. Ravi Kiran will ask only questions, I think, and he has thought nicely that instead of presenting diabetic macular edema again, he will go on to the panel, I think.
Thank you very
But
much,
make
sir.
it short, only 5 minutes.
Sure.
And
Very
to the
good.
next, whoever is there, the session, we received 20 minutes late, but we are trying to finish within that 5 minutes extra time.
Yeah. Very good afternoon, all respected seniors and my dear friends. As there is already a lot of discussion earlier on the management of DME options, so I just tweaked my topic into a few frequently asked questions with the experts.
Dr. Lalit Verma requests you to please come and join.
So as we all know, DME is the most common cause for the defective vision in working class population, so which affects the finances of family badly. And we are, India being diabetic capital of the world, we see a lot of patients in our day in and day out practice. So my first question to the panel is like, what is the role of FFA? Like, do we do this as a baseline to all the patients who are presenting with DME, or just before the focal laser only to identify the leaking macular aneurysms, or only in cases of non-responders? So,
Yeah, I think non-responders, where we start thinking that we may have to do laser.
The two situations are there. One is the visual acuity. You are doubtful that there can be some kind of ischemia playing a part. Probably FFA is the best investigation that you need to do. Otherwise, I agree fully with Malika that beginning it is not required, but if non-responders and those cases, you should.
No, I will do FA when the patient is coming for the first time in all of them.
as a baseline,
there
sir?
is a reason,
As a baseline.
as a baseline. There is a reason for that, because so many times, it's not one time, so many times, we have picked up non-perfusion area or CNP areas or neurostimulation elsewhere. You see, if the OCT is raised, maybe I'll not, but if the OCT is not, then 100% FA. You see, baseline, three things have to be done, irrespective of when the patient comes. Especially it is more than moderate NPDR. If more than moderate NPDR, you should always.
You need to further qualify while doing now.
Yeah, obviously not a patient who has one or two aneurysms, not in those patients. Mild NPDR exclude.
Let's go to the next question because only 5 minutes.
Okay. There are only 5 questions. The second one is about the dosing regimen of anti-VEGF in the treatment-naive patients. Is it always a loading dose followed by PRN, or is it right from the start of the treatment, is it a PRN or treat and extend regimen?
So I think loading dose is not really required. So you can just go with PRN and dosing. And as the CATS trial has already shown that, as we were discussing now, you give loading doses, eventually the eventual outcome is no longer different. So you can go with the PRN dosing.
Yeah, same. I also follow a PRN strategy.
So go to the next question.
Loading day is only for ARMD.
So my next question is, when to switch the agent? If you see non-responders, will you switch even after a single injection or after 2 injections, or you proceed with 3 injections or later?
Number of choices you are given are less after it is 2 or 3 injections.
2 or 3.
2 or 3 injections.
3, at least 3.
Yeah,
Okay.
yeah 2 or 3 I said, because if maximum response will occur in 2 injections. You see, if you see all the graphs, 1 injection graph goes like this.
Next.
Then after 2-3 injections it maintains.
Next.
Okay. Okay. Moving on to the next question. Will you ever start a treatment-naive patient if it appears as a chronic DME and OCT on a steroid, or only after a trial of anti-VEGF?
I think ma'am can.
So in any case, I will, sometimes if a patient is pseudophakic or about to become pseudophakic, I may start steroid also. Because it's not always necessary that you always start with antibiotic.
Okay.
So yes, in chronic cases, patients who have very large cystoid spaces, a huge amount of edema, I know the anti-VEGF alone will not be able to take care. So in such cases, I definitely start with a steroid. Even in phakic patients, because if 1 injection or 2 injections generally don't sometimes cause so much cataract, we need to take care of the edema more.
I think
So I
when
do use steroids as first line.
I think, sir, and Dr. Tinku, I think maybe you are comparing with the previous generation, I mean, with ranibizumab, let's say, but the newer anti-VEGFs, they are not inferior to steroid, as I showed so many cases.
No, the cases you showed still had recalcitrant edema. And so,
But
like you
many
said,
of them
edema is
responded
going
to aflibercept,
Yeah,
they did
the
not.
choice is between steroid and
Newer
newer
anti-VEGF.
anti-VEGFs.
Yes.
Okay.
Okay.
Next question, please.
Yeah, when coming to the cataract with coexisting DME, what will be the management option? Whether you treat DME first, followed by the cataract, or treat simultaneously giving the anti-VEGF injection at the time of cataract surgery, or first treating cataract followed by DME treatment?
DME first, because it can become recalcitrant because of the surgery itself.
Simultaneous. Previously means you should dry the macula first and then go for cataract.
Always DME first.
Ideally.
Last question. Any role of combined anti-VEGF and steroid?
Maybe.
With the newer anti-VEGFs, there's hardly any role. I showed the cases also. But earlier we used to do with Avastin, we used to add triamcinolone, but not now.
Generally, answer is no. Generally, answer is no.
Right? This is
Thank-
the last question.
Yes.
Yeah, thank you very much, and thank you audience for your patient listening, and I thank all the co-chair for a lively session.